The correct answer is C. However, this is not what typically happens for a patient presenting with this medical history. Typically, a patient like this one in the case study will have their symptoms labelled psychosomatic and either sent away or placed under the Mental Health Act for the historical eating disorder. This is deeply problematic and technically a breach of legislation, and I'll explain why. Part 3, Section 10 of the Mental Health Act 2016 specifically states a person cannot be considered to have a mental illness now just because they have previously been treated for a mental illness or been subject to involuntary treatment. The patient is engaging well with their community treating team, which should also be an indication that the Mental Health Act is not appropriate for this patient. Because the eating disorder is historical and not current, the QEDS assessment tool is not the appropriate screening tool either. Instead, the doctor should rely on the malnutrition screening tool alongside the subjective global assessment or patient-generated subjective global assessment, and if still unsure of eating disorder status, confirm cognition with the patient's existing treating psychiatrist and dietitian. While this patient has been expressing distress at her health status, that distress is quite reasonable. The patient has been distressed because she is losing weight and is unable to eat and drink to meet her body's needs. This distress is oppositional to what is seen in patients with eating disorder cognitions, where the patient's distress would be centered around their shape and size as too large rather than too small. The patient may still demonstrate cognitive decline and experience higher levels of anxiety, depression, obsessiveness, need for movement, and confusion, but these are also symptoms of malnutrition for all human beings, not just eating disorder patients. It's also more likely that given this patient has been treated in hospital for an eating disorder, that they may have medical trauma, which is also going to impact their distress levels now while in the hospital environment. Cognitive decline does not automatically mean a patient is unable to understand information and make informed health choices. However, the longer the patient is left without adequate nutrition in a format her body is able to tolerate, the higher risk there is of eating disorder relapse. As the malnutrition is treated, cognitive functions will likely improve naturally, even if they take longer than someone without a history of an eating disorder. Patients with eating disorders are more likely to have had pre-existing gastric complaints, and given this patient also has pre-existing global joint pain and injuries, involuntary vomiting and changed bowel habits, connective tissue disorders and autoimmune conditions should be assessed and pending results vascular compressions explored. There is a common misunderstanding among healthcare professionals that connective tissue disorders only impact joint function, but our entire bodies are made up of connective tissue, and that can also cause changes to kidney, liver, gallbladder, and heart functions and pancreatic functions, with symptom severity fluctuating based upon body position. This does not make it a functional disorder. It makes it one of connective tissue, and these things can be managed. There is a lot to consider with a patient like this, and even if the patient was considered to lack insight and capacity, she still actually has the same human rights and right to being an active participant in assessment, information, treatment, and decision-making as a voluntary patient, as specifically stated in in Part 5, Section 5A of the Mental Health Act 2016. Thanks.